Okay, thanks a lot, Neil. It's a real pleasure to be here at this meeting. This is the first time I've attended this meeting, and I think as Neil had mentioned, we've been working together over the last couple of years as therapies that have traditionally been systemically based in my neck of the woods as an oncologist have been making their way into earlier phases of urologic care. So I've gotten to learn quite a bit about the role of LUGPA and, more importantly, a deeper appreciation of, I think what we're both coming at from the same angle is just different perspectives, but how to use our talents to help our patients do better with these diseases. So I'm going to cover briefly today immuno-oncology and the emerging role of the urologist. It's a very exciting time right now in both spectrums, oncology and urology, and I think we're going to be seeing a lot more cross-discipline care as well as talks about how to implement this. My disclosures are listed there. This is just a brief outline of the topics that I'm going to cover. To start with, I think for this audience as well, it's not necessarily something new, but I think one of the things when we think about early stage disease is what is all the hype behind immunotherapy? You can't go anywhere in the last 4 years. It's on our TV stations, every NFL game. You see the people in Central Park, Opdivo, all sorts of different things. There's no question this has been breakthrough in the advanced setting. But is the hype really there as we think about moving to earlier stages of disease? So I want to give you a little background of why that hype is there. So shown here is the Keynote 45 trial. This was in advanced bladder cancer patients, and these were as advanced as you get. These were patients with metastatic disease who had previously gotten chemotherapy, who at the time of this trial, there were no other standard therapies approved. This data was actually presented only 2 years ago this fall at SITC, down where I live in Baltimore, just down the road in DC. This trial was a randomized trial in the advanced setting of an immunotherapy pembrolizumab targeting PD-1 versus standard of care second-line chemotherapy. And this was both in the United States, Europe, rest of the world. So that's why there's a couple different options there on the chemotherapy arm. Now, keep in mind in the chemotherapy arm, this was not great therapy. Okay, this is what was used, but only about 10% of patients responded traditionally to this therapy, and there was never an overall survival advantage. Well, what that trial showed was that the immunotherapy with pembrolizumab, about twice as many patients saw their tumors shrink, about 20% compared to 10%. What was striking, though, is that while that's not a high percentage of patients, if you were in that group that responded, those responses tended to be durable. In fact, most of the updates that we've seen, if you were in that 20% of patients, they still had not reached sort of a median duration of response. And that's what this graph shows, is this is the patients who responded and sort of their length of therapy compared to chemotherapy. So we're seeing a lot further out with the red on top compared to the blue on the bottom. But what got immunotherapy approved to stay, I would say, in bladder cancer was the fact that this trial was the first trial to ever show an overall survival advantage versus chemotherapy in advanced disease patients. So that was a breakthrough watershed moment for us in the advanced disease setting. We had never seen that despite the previous 30 years of trying with various sort of chemotherapies and combinations, et cetera. But this particular trial did show an advantage, and for that reason it was approved in the advanced setting, and then we've started seeing some things move up into earlier stages in frontline as well. The other thing, though, that got this approved is that when you look at the side effect profile compared to traditional chemotherapy, we saw a drug that was much easier to tolerate. This is not to say that they're side effect free, and we'll point this out as we talk about for earlier stage disease, but in general, the treatments that required us to interrupt therapy or give steroids for immune-related side effects were about half to maybe even a third of what we would see for side effects that interrupt therapy for chemotherapy. So only about 15% of patients having side effects that altered their ability to continue on the drug. Now, in the last 2 years in the advanced disease setting, we have seen 5 agents approved, all targeting PD-1 or PD-L1. This is just a brief summary of sort of responses and survival, and I just want to kind of highlight the generalities of what we see. When we are treating with monotherapy with only one agent, in general, we're seeing response rates of about 15% roughly across the board. When we combine immunotherapy, so with a different immunologic agent, potentially targeting a different target like CTLA-4 or others, we usually see the responses go up. When we look at frontline data from what we've seen so far in the trials that have been published, the response rate goes up a little bit for single agent to about 25%. And then the grade 3, 4 toxicity, those that require alteration of therapy or interventions, is about 15% with single agent therapy. So just keep that in mind in terms of in the metastatic setting. So shown here is the flurry of activity that we saw from the FDA in terms of approvals, both here in the United States and then in the European Union, for these individual drugs. So like I said, we have 5 drugs that were approved. If you go to May of 2017, it was every day you'd see a different one that was getting approved for a different setting. And that has revolutionized the way that we care for our patients in advanced disease, but also what we think about as far as drug development. So naturally, if we're seeing some successes in advanced disease, what we often do when we see initial encouraging results there is say, let's look earlier. Can we potentially see more patients respond? And more importantly to the point, are there ways to actually increase the cure rates of patients with localized disease by using agents that have shown some promise in metastatic disease? So it begs the question, though, just because we saw it work in advanced disease, does it even make sense to look at in earlier stage disease, including non-muscle and muscle-invasive bladder cancer? And so I'm going to just real quick kind of just go through a little bit of our understanding of, are these targets, PD-1, PD-L1, are they even relevant when we talk about a muscle-invasive or a non-muscle invasive bladder cancer patient? So this sort of cartoon here goes through some of our crude understanding of how BCG works. And it's kind of interesting, you know, we've been working with BCG for 30 plus years, but I would argue that only maybe in about the last decade have we had the tools from a basic science side and also the investigations to really tease out what are the true mechanisms of how it works. We've talked about the inflammatory response that it incites for years, but I think what we've come to understand is that there are components of the immune system that BCG hits on 2 fronts. We don't talk about it as much, but the innate immune response that it incites in terms of CD8 cells, NK cells, and tumor-associated macrophages is important. But BCG can be ingested either into the urothelial cell itself and then presented as either the BCG agent itself as an antigen, or in some cases lyse the urothelial cell to present urothelial proteins to surrounding immune cells to create an adaptive immune response. And the adaptive immune response is what most of us think is necessary for a memory function. It's still not clear whether or not the majority of the permanent sort of patients who are truly cured by BCG, if that's largely due to an adaptive or an innate immune response. But there's lots of investigation still going on. I think most people would accept that I think both components are important, at least for the initial response. But the parts of those components, when we look at different mediators of the cells that are involved, both the immune cells, the surrounding stromal components, there are a whole host of immune targets, and I just want to focus in on PD-1 and PD-L1 as their role in early stage bladder cancer to kind of go over what we know about that. So PD-L1 as a resistance mechanism to BCG has been suggested by a number of groups, and I think many of the first wave of trials that came out pointed to a study that was done at the Mayo Group when Brant Inman was up there at Mayo, who's now down at Duke. They looked at immunohistochemistry staining of patients, largely surgical, of non-muscle invasive, muscle invasive, a large series. This graph here is actually only a subset of 19 patients who had both BCG naive de novo tumors, received BCG, and then had recurrent tumors, and their tumor that was recurrent was also profiled. What they found is that in the patients that had recurrent tumors, they saw increased expression of PD-L1 by immunohistochemistry staining in about 70% of those tumors, compared to only about 20% at baseline. Now, this was one of the very first immunohistochemistry stains. There's been a lot of talk about, which stain should we use. It gave us the impression, though, that BCG might be a PD-L1 might be a resistance mechanism to BCG resistance. We also, though, have some hints of preclinical data from some experiments that have been done in animal models. Shown here is actually an animal experiment that was done at the NCI. This was from Vanderveer and folks using a PD-L1 antibody called avelumab. This was in an orthotopic, non-muscle invasive MB49 model. And what's shown here in the highlighted sort of PET positive, if you will, fluorescence of the mice is actually the uptake of PD-L1 in the avelumab. It's the actual tumor itself. So at day 21, when you look at the top row, these are patients that were treated with basically just saline injections. So they all still had their tumor still in the bladder, but with avelumab therapy, and this was peritoneal administration, so not intravesical, this was systemic administration, they saw significant tumor control, both by bladder weight and also by imaging. So it gave us a hint that potentially using a PD-1, PD-L1 agent might have efficacy in animals, so it made sense for us to look at this moving forward. So in the next couple slides, I just want to make sure and make everyone aware of which studies are going on right now that when they read out in the next 1 to 2 years could be immediately practice changing. And these cover diseases in the muscle invasive setting as well as non-muscle invasive. So this is actually a review that we put together actually in January of this year that has a table of the ongoing trials. It's interesting. I think it was eventually published in May. It's already out of date. There's already 4 or 5 on here that are not on this, but I think it gives you a flavor of how many trials using IO agents are ongoing right now throughout the world. Think back about this. You know, even before the IO agents made it, if we look back 5 years ago, even if we're looking at just intravesical or systemic adjuvant therapies, this list probably would have been cut in half. So there is an intense amount of drug development going on in these particular spaces, and I think that's a good thing. When we actually talk about the actual trials, I'm going to start first with the muscle-invasive bladder cancer setting. This is just a schema of one of the adjuvant trials. So this is high-risk muscle-invasive bladder cancer patients who have had cystectomy and either have T3, T4, or node-positive disease in the setting of no neoadjuvant therapy, or if they had neoadjuvant therapy, they could have T2 disease. And it's simple design, atezolizumab, which is a PD-L1 agent, versus observation, which would be the standard of care in these patients. This trial is fully accrued, just finished accruing in the last couple of months. In the adjuvant setting, it's going to take a little longer for us to get results than we see in the metastatic setting, but I think most of us are expecting to see some results from this hopefully in the next 1 to 2 years. If this shows a benefit for giving immunotherapy following surgery, then this would change our practice. And I think you'll see a theme here. So another adjuvant trial that is ongoing is looking at a different immunotherapy, pembrolizumab, targeting PD-1, very similar design, high-risk patients, randomize them to immunotherapy versus observation. This is actually a trial being led through the National Cooperative Oncology Groups here in the United States, led by Andrea Paulo, as well as a joint effort in Europe through the EORTC Clinical Trials Network. So again, looking at it, will it actually change survival? And then lastly, in the adjuvant setting, there's a trial looking at nivolumab, Checkmate 274. Again, very similar theme. Immunotherapy versus observation. This particular trial, however, is placebo-controlled. And we can argue whether or not that's needed or whether or not that should be there, but in this particular case it is. Now, if we move to the non-muscle invasive space, this is where I think things get really exciting, and I think there's a lot more room for discussion about sort of design, should we, shouldn't we, what should the benchmark be if these read out, what defines success, even beyond the way that the trials define them, and I really look forward to sort of a robust discussion about that. This is a trial being led by the Southwest Oncology Group. This is being led by Peter Black. This is looking at atezolizumab monotherapy in patients with BCG unresponsive non-muscle invasive bladder cancer. And this design of a single arm is a type of design that the FDA has encouraged in the last few years to spurn drug development in, I think, what all of us would agree is a very at-need population. So this is going to be looking at about 135 patients and then looking at the CR rates to atezolizumab therapy. Now, similarly, and I wanted to spend a little time on this because there's some new data actually that came out in the last 2 weeks. There's another trial, Keynote 57, that is in the non-muscle invasive BCG unresponsive population that's looking at pembrolizumab, the PD-1 agent, again, in a single-arm design. And just 2 weeks ago at the ESMO conference in Munich, we saw some data on the first sort of group of patients. So they reported out some early results in the patients with CIS. This trial is enrolling pure CIS, patients with CIS and concurrent papillary disease, and then it also enrolls patients that have pure papillary high-grade disease as well. And what they reported 2 weeks ago was that at 3 months, pembrolizumab monotherapy, about 39% of patients were in a CR at that point. So this was on cystoscopic re-exam, including biopsies and cytology, and there was no evidence of disease at 3 months. So that's encouraging. We're seeing some clearance of tumor at 3 months. One of the questions that I think we'll see in follow-up presentations of this data, as well as from the atezolizumab group and others, is the question about duration. So this data that was presented 2 weeks ago, I think was too early for us to get insights on that, but they did give us a little bit of a hint of the durability of CRs. If you look at this curve, essentially 80% of patients that had a CR at 3 months had maintained it at 6 months. If you do the math, that brings the CR rate at 6 months down to about 31%. We don't have results out further than that. Now, the toxicity, though, is something that I think we have to keep in mind. If we're talking about systemic agents entering into an earlier stage population, what is the toxicity rate? What types of toxicity? And then to the broader community of both physicians and patients, which of those toxicities are actually acceptable to this group of patients? And I think as far as the pembrolizumab data that we saw, no difference in terms of the rates of side effects. And I mentioned before monotherapy in the metastatic setting about 15%, and that's what we saw here, 12.6%. I do think, though, that it's important to note out, and it's in tiny print here, but when they say grade 3 to 5 toxicity, grade 5 means a patient-related death. And they did have one patient. They had one patient that truly, to their credit, they reported everything that happened, and it was an autoimmune colitis that led to a perforation. That's about what we see in the metastatic setting in all of the diseases. It's about a 1% or less autoimmune-related, potentially fatal event, and that's something I think that's been consistent throughout. The last trial that I'll mention briefly in the unresponsive setting is this trial, which is moving a little bit step further, which is looking at combination approaches. There's 4 arms on this, and it's a large trial. I don't think they're expecting all 4 arms to read out, but what they're looking at is, can we improve the response rate and durability by adding combination therapy? In this case, the BMS 986205 agent is targeting a different immunologic mediator called IDO1. And this trial is just beginning, and we'll have to see both, in terms of efficacy and then also side effects, how that works. So, in thinking about the urologic practice, this is the last sort of point that I want to make about thinking about IO therapies. I don't think anyone would question that this has been an advance for patients across diseases. We're seeing in advanced patients durable responses. I'm not sure we can use the word cure yet, because even in some of our earlier diseases, we're only followed out now to about 3 to 4 years. But we're clearly seeing patients that are alive longer than we have ever seen before with these therapies in a group of patients. So that's a good thing. But when we think about should we or could we move this to earlier stages, I would just mention a couple things to think about in terms of practice considerations. And I would say one is, how does your group feel about systemic therapy? It's one thing to have a champion who wants to do it and is going to take on doing it for their patients. But who's going to take the call on Friday at 4:30 p.m. when you're out on vacation and your partner is covering? Those things need to be talked about because it's important to have that coverage. There's a big education component. I think this is both physician, nursing, everywhere. And I will mention this is not just on the urology side. If these make their way into non-muscle invasive disease, Neil and I have talked, there's a huge education component that has to happen on the oncology side too. Most oncologists are not familiar with non-muscle invasive disease. So I think that creates an opportunity for crosstalk, to help patients. Infusion center infrastructures. is that something your practice has? Is that something you outsource with your hospital? Where does it happen? When does it happen? These are considerations. I think the relationships with your multiple specialties that would be involved in this are important to hammer out. Are they solid? Are they just casual relationships of necessity? Or are they really there when you need them? The toxicity management infrastructure, it's got to be there. The side effects are rare. These are far better tolerated than chemotherapy, but I think we have to respect the side effects, and we have to have a plan for how are we going to help that rare patient that really is pretty sick. And then I think when you get into this, if you're talking about muscle invasive disease, you have to have sort of a plan for what happens on the back end. If we're treating patients with high-risk disease, some of them occur metastatically, and is that a transition to oncology? Do some of them go to palliative care, and how do we do that? And I think the rest of that is there. I think there's trials, infrastructure, et cetera. But I think it's an exciting time, and I think for me as an oncologist, it's been a thrill to see this move into earlier stages of diseases. I have to tell you, I think earlier stages of disease is where we can make our biggest impact, because I think that's where the possibility for cure is highest. So I'm going to stop there. I think Ken has a couple of questions to lead discussion, but I think really interested to hear comments. Thanks.
So no, obviously a great talk. It's kind of a new dawning of a new era for immunotherapy. Two questions. One is, could you comment on, do you think all these patients need to be tested for PD-L1 or PD-1, number one? And then secondly, obviously there seems to be this yellow wave that may be coming that'll replicate what we did for advanced prostate cancer. And so again, I think it's something that, do you think we're going to have to bring into our practice and take that advanced prostate cancer clinic, so to speak, to a next level to do this?
I think those are both really good questions. I'll take the PD-L1 sort of staining question first. I don't think we need to do it yet in the clinical trials that are happening in the early stage disease. For the muscle invasive adjuvant trials, all of those trials stratify the patient by PD-L1 testing. So we will have results in there as to whether or not the benefit, if there is one, is it only restricted to a subset of patients. For the audience here, there's been a lot of PD-L1 sort of testing issues over the summer that the FDA has mandated both here and then also the EU in the metastatic setting in relation to some of the frontline trials that are moving on. So it implies that maybe we might need to consider this, and I think that could be an important factor as we look at early stage disease, but we don't know yet. And then talking about the second question about whether this is a wave kind of moving into the advanced practice for prostate model that we've already seen, I think it could be, but I think this is a little bit different than the advanced prostate model we've seen where not as many practices, I know Neil, you've led this before, where not as many have taken on the cytotoxic chemotherapy aspect as we have with the hormonal therapy. This particular therapy, I think, is sort of in the gray zone. I think it can be managed a little bit easier than chemotherapy, but I think the thing that this does for all of us, and I guess this is a good thing, it makes us be doctors again. Us as oncologists, we talk about we have expertise in systemic therapies, but the truth is that most of us are removed from our general internal medicine, hardcore training days. This has made all of us brush up our skills: endocrinology, rheumatology, cardiology. I mean, every system in the body can be affected by these drugs. So I think that needs to be taken into consideration as we think about bringing them into a practice. Is that an area we want to go? And I think for some, the answer will be yes. I think for others, they may say, I don't want to do that again. I have consultants for a reason. And I would say that that's actually happened on the oncology side too. So I think the short answer is I think it probably will for some groups. Yeah.
So that's a great answer. I agree with everything Noah just said. So let me just tell you, for those of you who are interested and you have a desire and you recognize that you certainly have these patients moving forward, we have there'll be some really good symposia and programs at the SUO in Phoenix this year. LUGPA will have its third Bladder Cancer Academy, February 28th through March 2nd in St. Louis. Noah will be there. He was there last year. And then, as I mentioned at the beginning of the program, myself and Noah and Ashish Kamat were working on a CME program with multi-sponsored from all of the immuno-oncologic companies, which frankly, most of them are here today. And if you need more information and literature, please visit them in the booths. And I agree with Noah, is that these are important drugs, and you do need to really know their AE profile, just like you do in advanced prostate cancer. These are different. There's always going to be differences, new things coming in prostate and in bladder and kidney. And, it isn't for a dabbler. And, one of the themes that LUGPA has been promoting over the years is collaboration within our large groups and specialization. So thanks to, Noah, who's been really helping us along the way, and many of his colleagues. So great. Thank you, gentlemen.
Thanks.